Good afternoon. My name is Katie Billing and I'm from the Commission on Excellence and Innovation in Health in South Australia, Australia. I'm very excited to be joining colleagues across Australasia and potentially further internationally for this opportunity to talk about building capability in our health system for high-performing, self-sustaining clinical networks. Before I get started, I would like to acknowledge that I'm presenting this session today from the lands of the Kaurna people, and I pay my respect to their spiritual relationship with their country. I also acknowledge the traditional custodians of the various lands on which you are all joining us from today, and any Aboriginal or Torres Strait Islander people participating in the sessions. I'd also like to pay my respects to elders past, present and emerging and celebrate the diversity of Aboriginal peoples, their ongoing cultures and connections to the land and the waters. And the picture on the screen is of our Torrens River on Kaurna land here in Adelaide, sitting underneath the footbridge that connects our beautiful city with our Adelaide Oval, our stadium. So the Commission on Excellence in Innovation in Health, or the CEIH, is our acronym. Vision is together, let's create better healthcare for South Australians. Together is about doing things as a team and recognising that we can't do anything on our own. And absolutely let's is about being inclusive. Create for us is about the opportunity to imagine and to do things differently. And better is really about our commitment to measurement and actually recognising that if we were talking about excellent healthcare, that's going to be really difficult to be able to quantify. So actually, if we talk about better, what we're talking about is ongoing improvement and ongoing improvement towards excellence for healthcare for South Australians. So we're a government agency that sits separately to the Department of Health and Wellbeing in South Australia. So we are government, but we're a really tiny government agency, and our Commissioner and CEO reports directly to our Health Minister at a state level. So we want excellent health outcomes and experiences for everyone in the system, for patients, for consumers, for our healthcare staff and for everybody in and around the community. And what we want is to see consumers, carers and clinicians engaged in the design and delivery and the evaluation of health services. And by doing this, what we believe is that we'll see increased confidence and pride in the South Australian health system and a culture of health system of innovation and striving for excellence, and ultimately to see South Australia recognised as having an excellent health system and being the leader that it is in healthcare and in healthcare innovation. To deliver this, I guess broadly speaking, very broadly speaking, we work in some different ways, and importantly, building capability, which is what I'm here to talk about today. We also work in the space of advice and support in partnering and connecting and bringing people together, and also innovation, excellence and best practice. Alone we can do so little and together we can do so much. And I guess this famous quote from Helen Keller is not quite so beautifully and succinctly put by myself as I speak with people, and that is that I believe if we empower, we should be empowering people to work together so that they can fix what's broken and do amazing things. And so for us, this is what networks are all about. There's no shortage of ideas in our health system, nor people reaching out for help to solve a problem. And as an agency that's all about working with others to solve problems, we knew that we had a responsibility to use networks, or the commonly called clinical networks across systems elsewhere and also historically here in South Australia, to use networks as a modality to improve things. With so many options though, certainly so many areas of need, we knew that we needed to find a way to develop sustainable, scalable model to bring the clinicians, carers, consumers and the community together as a network of individuals. So the CEIH's capability framework and model for transition that I'm here to talk to you about today builds networks and supports their maturation so that they learn to fly and leave our nest as self-sustaining communities of practice, hence creating capacity for new networks to be nurtured and ultimately building depth, knowledge and strong connections across the health system. So the challenge for us, I guess, is we knew that we wanted our networks to leave a footprint. And in South Australia, as I'm sure in many jurisdictions, there has been this notion of clinical networks for a long time. And we knew that many of those networks have not left a footprint. So, they may have been funded or formed in one iteration of governance or another, and then over time, they've lost their funding, whether that's administrative support or whatever it was that drove them coming together regularly, and ultimately fallen apart and not continued to work as a network. But we also knew that there were some really great examples where the group of people who'd been brought together under a government structure called a clinical network actually had sustained those relationships and had sustained the impact that they're having in the system. So we had a little bit of a look at those and wanted to understand what it was about them. And that's what I'll talk to you about a little bit in more detail around our capability framework. I guess the evidence that we looked at indicated that clinical networks can be really effective vehicles for quality improvement and service delivery and patient outcomes, and certainly across a range of different disciplines. But we do know that there's variability in the success of them having a sustainable impact, and certainly variability and very light on evidence around them being able to have a long-term impact in really complex areas of healthcare. Part of that challenge we felt was around this notion of mastery and the notion that many of the people who we bring together to solve health system problems are already masters. So they perhaps are advanced practitioners in their area of clinical expertise. And what we are suggesting here is that they are unconsciously competent. So they're at a point in their day-to-day career, in what they show up and do every day at work, where they're masters and where people expect them to just know the answer, and perhaps on some level they work with a degree of automaticity, so that they respond because they know, and they are masters of what they're doing. So when we bring them together as a group, and certainly for clinicians when we bring them together with a group of consumers and with other healthcare workforce, what we recognise is that we're actually asking them to step back a couple of steps and actually be operating in that consciously incompetent space, and so to not be a master anymore. And so that's to suggest that as a medical practitioner, for example, or as a nurse practicing at the highest levels of their area of expertise, that they'll actually be a master. But actually, when they come back into this space where we're looking for them to learn how to work together, learn how to solve problems, learn how to build sustainable solutions, and learn how to innovate and work in a place where we have a real impact for healthcare outcomes, we're actually asking them to be consciously incompetent, and we're asking them to learn. And so the premise for us that we're actually looking at a capability framework for our statewide clinical networks. The other challenge that we heard about, particularly from consumers, is around this idea of silos and islands, and certainly, when they come together, what a catastrophe that is. We had to identify ways of building non-clinical capability. And I would include in that the human factors to build meaningful partnerships, and also to work between the clinical interface and policymakers, administrators, and the community to achieve results. What we didn't want to see, in effect, is, I guess, the statewide clinical networks that we were working with being built around single organs, and often they are historically built around cardiology or built around respiratory care, and that what we're actually seeing is a disease process, not a singular human. And so what we heard from consumers is that these networks needed to be integrated. Our capability framework involves 6 areas, and so they are innovation and improvement, partnerships, clinical informatics, human-centred design, leadership, and most importantly of all, this notion of achieving impact. And I'll go through those in a little bit more detail. Our framework is a way to identify need, to plan education and skill development, and to measure capability in our statewide clinical networks, specifically in the steering committees of those statewide clinical networks, which is from 12 to 20 individuals. And I guess what we want to do is to support those networks in their eventual maturation into a statewide clinical community of practice through the model of transition, which I'll talk more about. The framework is based on the theory that consumers, carers, clinicians and administrators are experts in their own individual domains, but are often frustrated about being able to introduce or to sustain system improvement. We propose that bringing groups together to form networks alone does not result in a sustained increase in capability, and certainly for our model and for our limited capacity, it doesn't provide us with a sustainable model for clinical networks. So underpinning the framework that we're using is Wagner et al.'s work on communities of practice and the model for transition. So with the proposition that a statewide clinical network is formed where there's a problem to be solved and a need to connect those who can solve it, I would also suggest that there is also another element to that, and that is capacity within our organisation to support that network. And so that's the need for the sustainable model. Our goal is to create networks that are connected, self-sustaining and high-functioning and equipped to achieve sustainable change. So we partner on the network's innovation and improvement projects, but our focus is on delivering a mature network that's ready to transition back to the system. So once a network leaves our nest, we continue to partner with them on their projects and support their connections, which is really important as and when they need us. And as we transition networks, we create capacity to respond to emerging areas of need. Really importantly, what we want to do is leave a footprint. We want these networks to be able to leave an impact and a footprint on the system, and not just to exist as a meeting or a forum, which is certainly one of the things that we've seen historically here. So statewide clinical networks identify the initiatives or projects that will help them achieve their collective aim, and in doing so, they, through those projects, become mature and experienced and skilled to be able to function independently, ultimately alongside of the Commission on Excellence and Innovation in Health. And so the relationship with the CEIH changes to one of partners where capability building opportunities and that support to have a voice in the health system continue, but the group is able to function more autonomously. And so what this means for us is that whilst we're leaving a footprint in the system and building capability in the system and capacity for the system, for our health system in South Australia, for ourselves as an organisation, we're also building that capability by having that broader network, but also building a system where we do have vacancy, so where we hope to be able to respond to areas of need in the future. So we have the eggs in the nest and we're really supportive and holding their hand, but actually we're working towards them flying from the nest and creating that vacancy for us to be able to move forward. So currently, just briefly, so you know where we're at in South Australia, we have 8 statewide clinical networks: cancer, cardiology, urgent care and palliative care, adolescent transition care, clinical genomics, surgical and perioperative care and chronic pain. And we're also working with some of our historical networks, so networks that have been formed under different historical governance arrangements within our Department of Health in South Australia. And we're working with them with a model that we've developed for communities of practice. And I'm not focusing on that today, but that's another area that we've certainly looked at, is what does a community of practice really mean, and what are the domains and the criteria for success for a community of practice. And so we're working with these 8 specific groups currently, so that in the next 2 to 5 years, we will see them transition through the model for transition into clinical communities of practice. So the capability framework I mentioned earlier has 6 areas, and I'll go through those in a little bit more detail now. So the capability areas, firstly, are leadership, clinical improvement, innovation, and human-centred design. And so you can see from the list that leadership is really about recognising that if you're one of the, I'd say, up to 15 or 16 people who has been lucky enough to get a spot on a steering committee for a statewide clinical network, then absolutely there's an importance that you build and grow as a leader. And our clinical networks are soon to be led not just by clinicians. So we do have medical leads, we have a allied health lead for one of our networks, and we're soon to introduce a co-leadership, which will be a community leader alongside of a clinical leader for our palliative care statewide clinical network. And really, this is about building their leadership and building their ability to influence and to form strategy. Clinical improvement and innovation is fairly straightforward, I guess, but really for us, really importantly, not about a particular methodology. So we have been methodology agnostic in our organisation, and really it's about recognising the change or the impact that you're trying to have, and then identifying with our support from a methodology point of view which approach is going to be best to have impact at the end of the day. Human-centred design is another area that we've identified, and for those that aren't familiar with the term, human-centred design is really for us the next step from co-design, which is the thing that people talk about a lot in healthcare. Really, human-centred design is not a one-to-one, so we're not talking about have we engaged a consumer and a clinician in the co-design process. What we're saying is have all of the people who are involved in this process been involved in the co-design of the solution. Importantly for human-centred design, we're also looking at the capability of those steering committee members in our clinical networks to build connections with research and other institutions, also to communicate through multiple channels. So we do work with them on things like their comm strategy and how they are communicating back to the broader public and how they're managing their stakeholders. And the next three areas are clinical informatics, and this is really, really important to us. Really what we want is a steering committee of people at the end of their time as a clinical network who are able to ask the right question, absolutely, but also to start to build capability in terms of understanding data, why it's important, and for many of them starting to understand how we use data to evaluate. And we know that if people are not evaluating and are not able to have a degree of digital literacy, that is a huge part of why we're not sustaining change in our system. Partnerships, we don't specifically call out consumers as partners because for us that's an assumption, and it's something that we expect is that consumers are a core part, and certainly from a membership and in terms of reference point of view, they are at the core of all of our clinical networks, and to the point where, as I say, we have a community leader stepping in for one of our clinical networks to lead specific areas of their vision and delivery of what that network wants to achieve. So very much partnerships are important, and we also recognise the need for positive culture and clinician wellbeing. So how are we building clinician wellbeing and looking after the people who provide the care into the work that our networks are doing, but also for them as system leaders, how are we making sure that they always consider that in the work that they're doing. Last but definitely not least is achieves impact. And this is really our catch-all for the stuff that is really difficult to describe. And this is about how we really, rather than what perhaps has happened traditionally is that a clinician comes with a problem and we perhaps say to them, yeah, let me help you. And we pop a blindfold on and we grab them by the hand and we walk them down what is to them a dark corridor. We knock on some doors, we take them through some turns and up and down in the lift. And then at the end, we come out and say, here you go, here's your solution. You know, we might have asked them a few questions. What we're suggesting is that the team members from the health system that we're working with will actually have their eyes open through these processes, and as we find our way and we navigate through the system, their eyes are wide open, and they're a part of that, so that they learn which corridors you might need to go down, which doors you might need to knock on, and who you might need to partner with to get these things done. So very important to us, but also, again, how are they knowing that they're achieving what they said they would achieve? And we really are looking to build accountability into that for each of the clinical networks as well. So within those areas, I guess we wanted to be able to select the right improvement tools to align to each of those capability, and it helped us to first go back and look at the individual capabilities that we were trying to address. And during this process, it became really noticeable to us that the capability questions we were asking the clinical networks could be categorised as requiring effectiveness across a number of dimensions. And for some, there was sort of one clear primary dimension, or for others, there might be a combination of these dimensions. But broadly speaking, the method is the how. And absolutely, this includes knowledge of an improvement methodology or procedure for accomplishing or approaching something to achieve the required output. And it is also about taking a systematic approach to solving simple or a complex problem. People related is about behaviours, and absolutely that is about including compassion and being motivated and effective leaders at all levels, and also I guess leadership for improvement and change across the system as leaders. Systems and information, the know-how, is about, I guess, including access to data, to systems and information, the ability to interpret data for some people, but also information systems for learning at a local, regional and a national level. And stakeholder engagement, the together, is where we talk about that communication for cooperation and collaboration. It includes the ability to partner with staff, patients, and communicate for improvement. So really, I guess, again, talking about how we want these groups to leave a footprint, but also how we want to build capability across our health system. We then work through capability development planning. So this is just a quick screenshot of what that would look like in terms of one of the domains. So leadership being the domain, some of the capability questions that we ask, and I haven't gone into those in detail, but we're really happy to share with people if they're interested. And then the dimensions within that, so where we might be looking at the dimensions, and then starting for each clinical network to build out what is the building activity that we're going to do, what is the improvement tool for that particular domains that we need to do, and also importantly for us, is that something that we can internally deliver, or do we need to look at an external provider or an external source? And obviously, again, this is all about building this into the work that they're already planning to do. When we're not able to do that, we may actually offer a specific module, if you like, of training or development for that steering committee or for members of the broader network as well. So really quickly, I'll just give you an example of some of the areas and just quickly flick through this. But we start with an assessment. So to assess the capability at the beginning, we use a SurveyMonkey platform. And ask a series of questions that are designed to give us insight into how the network is travelling against each of the capability domains. Once we receive that, we're able to, obviously we check back in with the lead of the network or leads of the network, and we use a heat map to be able to show them how they're tracking towards achieving that maturity as a statewide clinical community of practice. So over a 2 to 5 year period, depending on the size and complexity of the network, we expect that these will turn green and that those areas will be fulfilled. We also use different ways of displaying that data for the group so that they're able to see the areas that they need to develop in. So you can see here, for example, under Achieve's impact, that this example, setting clear performance standards to monitor data and to assess their organisational performance as a network is lacking. And so how are we going to know that we've achieved what we said we were going to achieve is a really important area for them to grow in. We find that clinical informatics is often an area where there's development needed, and that's not at all a surprise to us. And we certainly at the CEOH have an entire directorate of our organisation that focuses around clinical informatics. We then present information, I guess, about where they're doing well. So for each network, where are they doing well, and a bit of a report card on areas for improvement as well, and then start to work with them collaboratively to build that out as we support them in that maturation process. So I guess I just wanted to acknowledge members of my team. So often these ideas are written on a whiteboard by me with a texter marker, and 4 or 5 days later I get it back making sense. So I just want to acknowledge Katie, Mary and Melissa, and yes, there's a theme of Katie's there, but specifically Katie Mallow is currently tasked with leading our statewide clinical networks as our networks program director, and so for her, her accountability and her role is actually about building capability in these teams, not about delivering their projects and their initiatives. It's 100% focused, and her team is focused on coaching and mentoring these clinical networks to achieve this capability and then prepare to transition through our model of transition. So I'm really grateful, as I say, for the opportunity to speak with you today, and I'm really happy to share further information, recognising that this has been a challenge for us, and yes, I haven't spoken about the challenges, and I'm really happy to talk to you about those in the Q&A afterwards. So looking forward to that shortly. Thank you.